right, welcome back. We're jumping right back into pertussis, picking up where we left off. In this explainer, we're going to tackle the diagnosis, the treatment, and of course, how to prevent it. Let's get right to it.
Okay, let's kick things off with a classic exam-style question just to get your brain warmed up. When you're looking at a lab report for Bordetella pertussis, what are those two key visual descriptions, those buzzwords, that should instantly scream pertussis at you? Keep that question in the back of your mind as we move through this first section.
So first things first, how do we actually confirm that we're dealing with pertussis? Getting a solid diagnosis is step one, and it all starts with getting the right sample the right way.
Okay, this is super important. It's not just about getting nasopharyngeal secretions. The real key here, and a classic exam trap, is the type of swab you use. You have to use alginate or Dacron swabs. Why? Well, if you use a regular old cotton swab, the fatty acids in the cotton can actually stop the Bordetella pertussis from growing. That could lead to a false negative, and you'd miss the diagnosis completely. So remember, no cotton.
Right, so you've got your sample with the right swab, but you can't just throw it on any old agar plate. Nope. Bordetella pertussis is what we call a fastidious organism. It's super picky about where it grows. You absolutely have to know these two special media for your exams, Regan Lowe and Bordet Gengou. A pretty easy way to remember one is that Bordella grows on Bordet Gengou. And believe it or not, culture on these is still the gold standard for diagnosis. And here we go, our first huge visual buzzword. This is the first part of the answer to our starting question. After you let it grow for about 3 to 5 days, the colonies have this really unique look. They're described as looking like little mercury drops, or sometimes bisected pearls. You see that description on an exam, you think pertussis, period. And this slide right here, this is the second half of our answer. You take those mercury drop colonies, put them on a slide for a gram stain, and what do you see? You get these tiny, ovoid, gram-negative coccobacilli. But the real giveaway is how they're arranged in these loose clumps that create what's known as a thumbprint appearance. So there you have it, mercury drops and thumbprint. Lock those two in your memory.
So this slide just puts it all together beautifully. You see the whole workflow, from using that alginate swab to plating on the special Regan Lowe media, and then identifying those two key visual clues. You'll also notice it mentions PCR. That's because PCR is becoming way more common. It's much faster, it's more sensitive than culture, and it works by targeting a specific gene called IS481.
Okay, diagnosis is nailed down. We know it's pertussis. Now, how do we treat this thing effectively? Let's talk about the drugs.
This is about as high yield as it gets, folks. If an exam question asks you about pertussis treatment, your brain should immediately go to Macrolides. That's it. Specifically, we're talking about Azithromycin for 5 days or Erythromycin for a bit longer. Simple, direct, and these are easy points you do not want to miss.
And this just drives that point home. Macrolides are your #1 choice, your go-to. But what happens if your patient is allergic? Or what if you're dealing with a resistant strain? You gotta have a backup plan, right? Well, your backup is cotrimoxazole. That's your second-line agent. Good one to have in your back pocket.
All right, we've diagnosed it, we've treated it, but honestly, the best medicine is preventing it from happening in the first place, right? So let's talk prevention. This is huge from a public health perspective, and you definitely need to know it.
The strategy here is really a two-pronged attack. First, you've got immediate containment, which we call chemoprophylaxis. This just means you give erythromycin to everybody who lives in the same house as the infected person. You do this to stop the bacteria from spreading. The second prong, and this is the big one for long-term control, is vaccination. Okay, pay close attention here. This is super important and comes up on exams all the time. You have to know the difference between the two vaccine types. You have the older DPT, which is a whole cell vaccine. It uses the entire killed bacterium. Then you have the newer DPT, which is an acellular vaccine. It only uses purified little pieces of the bacteria. The easy way to remember this is the A in DPT is for acellular, and you can think of it as also safer. It's safer because the whole cell DPT had a higher risk of side effects, including some rare but scary neurological issues. That's why DPT is a big no-no for kids over 5 or 6. Now here's a really cool little tidbit, and a great answer to a potential why question on your exam. Ever wonder why we lump pertussis in with diphtheria and tetanus? Well, it turns out that the pertussis part of the vaccine acts like a hype man for the other two. It's what we call an adjuvant. It basically revs up the immune system and makes the body's response to the diphtheria and tetanus parts way stronger than they would be on their own. Pretty clever, right?
All right, team, let's bring it all home. We've gone through a ton of details, so now we're going to boil it all down to one single power-packed slide. This is your high-yield summary, perfect for that last-minute review right before the exam.
This table right here, this is your golden ticket. For diagnosis, you need to know alginate swab, Regan Lowe media, and your two big buzzwords, mercury drops and thumbprint. For treatment, it's easy, macrolides. And for prevention, it's all about that crucial difference between DPT, the whole cell vaccine with neuro risk, and DPT, the safer acellular one. Screenshot this, write it down, do whatever you need to do, burn this into your brain.
And to wrap it all up, let's put it into practice. Here's a quick clinical scenario to make sure this all sticks. You've got a 7-year-old child who's behind on their immunizations. Based on what we just discussed, which pertussis vaccine is absolutely contraindicated, a hard no, and why? Think it through. This is exactly the kind of clinical application you're going to see.